Hello and welcome to this mini symposium sponsored by Omron, where we're going to be looking at home blood pressure monitoring. And I'm really pleased to be joined by friend and colleague Richard McManus, who is Professor of Primary Care at the University of Oxford. I'm Brian Williams, I'm Chair of Medicine at University College London. And we'll be giving talks in a moment looking at the role of blood pressure monitoring at home in the management of hypertension. But I'm going to begin really looking at the potential advantages of home blood pressure monitoring and potential future perspectives. And then Richard will give his talk looking at the role of telemetry. Okay, so let me remind, these are my disclosures, and let me remind everybody that it's actually 125 years ago that the first publication by Scipione Riva-Roche describing blood pressure measurement with a conventional cuff type approach was first published. Quite extraordinary when you think about it. Even more extraordinary when you think that actually the device that's pictured there is a little different from many of the devices we were using up until a few years ago. Now, despite the fact that there's a long history of blood pressure measurement, it is well known that despite all this information, you see here the European guidelines with a lot of information about how to do office blood pressure measurement in a standard way. This new document that's just been published by the European Society of Hypertension on guidelines for office and out of office blood pressure measurement. Lots of information in the public domain for doctors about how to do this. Despite all this detailed guidance, there is no doubt that the measurement technique for blood pressure is often poor in routine clinical practice. And there's also no doubt that if we rely entirely on office blood pressure measurement, that we will not be able to detect masked hypertension and white coat hypertension, because these are only detectable by using out of office measurements. In the last few years, and this is the guideline from Europe in 2018, there has been a shift in emphasis towards out of office blood pressure measurement. In fact, if you look at this mention here of the new concept highlighted in that European guideline on hypertension 3 years ago, wider use of out-of-office blood pressure measurement with ABPM or home blood pressure measurement, especially home blood pressure measurement, as an option to confirm the diagnosis of hypertension, detect white coat and masked hypertension, and monitor blood pressure control. So the first time that there's been such a strong emphasis on wider use of out-of-office readings. And you can see here, for the confirmation of diagnosis, either continue with repeat office blood pressure measurements using standard measurements, or go straight to out-of-office measurement with ABPM or home blood pressure. And this endorsement by guidelines in Europe and indeed the United States for wider use of out-of-office readings has really led to a big increase in the use of this technology. Now, both comment on white coat and masked hypertension, and I don't need to explain what that is to this audience in terms of white coat and masked, but it's important to remember that the white coat and masked effects can occur both in untreated and treated patients. And we know that white coat hypertension is most common when office blood pressure is in the grade 1 hypertension range. By that, I mean, if you have somebody in the office whose blood pressure is grade 2, from our own data and the data of others, it's very unlikely that person's blood pressure will be normal on home readings or ABPM if they're grade 2 in the office. Similarly, masked hypertension, this is more common if office blood pressure is in the high normal range. When you measure office blood pressure, if it's below 130/80, it's very unlikely that that patient's going to turn out to have a high blood pressure at home. So there are 2 pointers to how you might prioritize the use of out-of-office blood pressure, for example, to exclude white coat and masked hypertension in terms of diagnosis. But the thing that's really changed, and perhaps the only advantage of COVID, this terrible pandemic that's affected the world, is that, of course, most parts of the world, this is including our own country, the NHS, stay at home, stay at home, stay at home, stay at home. In other words, don't go to the hospital, don't go out and visit the pharmacy or get your blood pressure checked. And the the ESC issued guidance for the diagnosis and management of cardiovascular disease during the pandemic, and specifically mentioned the whole issue of the isolated hypertensive patient at home and how they should approach monitoring their condition. So there's no doubt that COVID has led to an increased use of home monitoring at home, and national guidance has been issued by many countries about how people should do that. And this experience, in my view, is likely to lead to a major shift to wider use of self-measurement of blood pressure at home. It may be one of the positive things that comes out of this pandemic, the wider use by patients of home blood pressure monitoring to look after their blood pressure. Now, when we look at the advantages of home readings, well, they are often cited in this way as from the European guideline. They help identify white coat and masked hypertension, as I've mentioned. They're relatively cheap devices and widely available. They measure the blood pressure in the home setting, which may be more relaxed than a doctor's office. That's what the guideline says, but actually may also be more relevant to the patient's usual blood pressure. And it doesn't just need to be the home setting. You can do it in other settings as well. The patient becomes engaged in the management of their blood pressure, not just the measurement of their blood pressure. And I'm sure Richard will talk about this, and this was cited in the US guideline as a justification for home blood pressure measurement. It might improve patient awareness, adherence, and other aspects of their care. And of course, the device is simple to use, so blood pressure measurements are easily repeated and can be used over longer periods. So you get a much better impression of the overall blood pressure load the patient might be experiencing over a number of days, unlike ABPM, which is focused just on one day. Of course, like every methodology, there are disadvantages, and the ones that I wanted to highlight here that were highlighted by Europe, where they said only static blood pressure is available. In other words, seated measurements. Well, that's changing, and I'll come to that in a moment. The potential for measurement error is obvious, but you can actually check to see whether a patient can measure their blood pressure accurately. And no nocturnal readings was commented upon, but of course, there was a caveat to that in the sense that there were devices were under development to allow nocturnal readings to be measured. And then we move to the recommendations by Sturgio and colleagues from the ESH, almost identical advantages and limitations. And I just draw your attention again to this one: no information of BP at work or indeed during sleep. Well, I don't think that's necessarily true, because of course, people can take their monitor to work if they wish, if they're doing home monitoring. But of course, sleep has been a perennial issue because mainly home monitoring is focused on daytime. But as they point out, novel methods are now being developed to actually allow blood pressure to be measured during sleep at home, which will extend the repertoire of home blood pressure measurement. Whenever you talk about this, the question that often gets asked, and in fact, Richard and I are on a national committee for the NHS, and this has been a topic of extensive discussion: how often and how should you measure the blood pressure at home? So this was the European guidance in 2018. It is the average of all readings performed with a semi-automatic monitor for at least 3 days, and preferably 6 to 7 consecutive days before a visit. With readings in the morning and the evening, 2 measurements taken a minute apart while seated in a quiet room, etc. So trying to replicate the doctor's office type scenario, sitting quietly before the measurement, and then 2 measurements 1 minute apart, averaging all the readings. The ESH guidance, which has just been published, very similar: measurement for 7 days, at least 3 morning and evening measurements before drug intake if treated, and before meals, and 2 measurements on each occasion, a minute apart between them. So we've now got a level of consistency about how to do this. If we look at the definition of hypertension, this is pretty much consistent around the world. This is the United States: 140/90 in the clinic, 135/85 on home ABPM, home blood pressure measurement average. This is what the ESC said. The diagnostic threshold for hypertension is 135/85, equivalent to an office blood pressure of 140/90, based on the average of 3 to 6 days of home readings. And compared with office blood pressure, home readings provide more reproducible blood pressure data and more closely related to organ damage, particularly LVH. And this was, in fact, the chart from the European guideline about the diagnosis. You'll see the equivalence of home blood pressure at 135/85. Now, in terms of targets, much less evidence base around the optimal target, but we know that as your blood pressure comes down in the office and gets lower and lower, it becomes closer to the out of office readings. And therefore, if the office target for most patients or many patients is less than 130/80, which it is certainly for younger patients, then the equivalent home is certainly less than 130/80 on average. So diagnosis at 135/85, target below 130/80 on home measurements. Now, for some years, people have said, well, we don't know the relative merit of home readings in terms of predicting outcome compared to, for example, office blood pressure, or quite a lot of data we have with ABPM, but that data is now beginning to change. And this is a very nice paper coordinated by Dr. Kazu Kario from Japan, which Richard and I worked on, which looks at a number of studies now published with home blood pressure monitoring, variety of measurement periods, and the correlation with a whole variety of outcomes in community-based studies and from clinic coordinated studies from established investigators. So there's no longer a deficit in the data in relation to the link between home readings and outcome. So home blood pressure monitoring is guideline recommended. It improves diagnostic precision, identifies white coat and masked hypertension, gives us better patient engagement in the care process, better prediction of organ damage versus office blood pressure, and increasing evidence of better prediction of outcomes, but perhaps not quite yet as strong as ABPM. But then those two disadvantages that I mentioned earlier, the comment that only you get seated or static blood pressure with home, and there's no nocturnal readings. Well, that's beginning to change. And this is a new device which is designed to fit on the wrist. But of course, one of the challenges with wrist devices in the past is that they sometimes hang down and that are not at heart level. But of course, that changes when you're asleep in bed because your arm is pretty much at the same depth as heart level. And this has been validated both for conventional validation guidelines and also by somebody wearing a cuff-based monitor around the upper arm versus the wrist-based monitor here, and you see very good correspondence of the blood pressure readings. And of course, there's no tube involved here, so this is going to be less disruptive to nighttime sleep. Quite a clever idea. And the way this works is that once you go to bed, you press the night mode, and it will make a reading at about 2 a.m., 4 a.m., and 4 hours after pushing the night mode. So you'll get 3 readings during the night, and these can be averaged to give a nighttime blood pressure value, which we know is very good and very predictive of outcome in outcome studies on ABPM, for example. The other device that's now becoming available deals with that criticism that home blood pressure monitoring is only about seated measurements at home, because this is a device in which an inflatable cuff has been inserted into a strap for a watch, so-called heart guide device. It actually was regarded by Time magazine as one of the best inventions of 2019. The idea is that when you're wearing this watch, you put it up at heart level to make the measurement, click the button on the watch, and it will inflate the cuff at heart level and make a measurement of blood pressure. Again, quite well validated, looking at comparisons with ambulatory blood pressure readings. Here's a study I did with Dr. Cario, and you can see really good correspondence between measurements with this watch and ambulatory, providing you use it in the correct way. Now, the advantage here is it measures home blood pressure. You can do it seated, just as in a home device. Again, you can use it on multiple days like any other home device. You get standard seated measurements. But on top of that, you can press that button at any time and get opportunistic active measurements. So in many ways, this is a bit of a hybrid between the seated home blood pressure measurement and the sort of active multiple measurements that you could take during a day, for example, with ABPM. So we're going to be very interested to see how those different types of measurement correspond to outcomes, and studies to that effect are ongoing. So in many ways, blood pressure measurement has undergone a massive transformation. It's been a huge tech challenge. These are the monitors that we're all familiar with We're now beginning to see the emergence of tubeless blood pressure monitors, so the battery is incorporated into the cuff, which is more convenient for patients. We're beginning to see the emergence of these blood pressure monitoring devices within a watch strap. And again, I've illustrated one of those. We're also beginning to see the development of these home nocturnal blood pressure monitors, either with a new type of monitor or a traditional monitor that's been adapted for nighttime mode. And of course, we're beginning to see the emergence of patches that try to measure blood pressure through contact or optical techniques, which I think at the moment I'm still somewhat skeptical about the accuracy of these relative to cuff-based technologies. But in conclusion, after 125 years of conventional blood pressure measurement, the last decade has really seen a major expansion of home monitoring. This has been accelerated by the pandemic, which has necessitated more remote care. It's also been accelerated by recent advances in technology that have really created more sophisticated devices. They've expanded the spectrum of measurement beyond home seated blood pressure to include daytime and nocturnal BP measurements on multiple days. But I would finish with this comment that blood pressure measurement is not a gimmick, it's not a toy. Rigorous validation of devices remains important if they're to be used in routine clinical practice. And it's incredibly important that whenever we're considering any device, that we look very carefully at the validation and make sure that it is an approved, validated measurement device. Anyway, at that point, I'm going to finish, and I'm going to hand over now to Professor Richard McManus from Oxford, who's going to give his talk on telemetry and self-measurement in the control of blood pressure. Over to you, Richard.
Good afternoon, and thank you to Brian for that introduction. As you've heard, I'm going to be talking about telemonitoring and self-management, and Brian has nicely teed this up. So these are my disclosures. And just to give you a quick overview to start with, I'll discuss part of the problem that we're all facing with control of hypertension, think a bit about what attributes we need if we're going to do successful self-monitoring, think about telemonitoring, self-management, and how these would work in terms of a digital intervention before bringing it all together. So what's the problem? Well, blood pressure control is suboptimal. These data are from the UK, but about half of people are unaware they have hypertension, even at the standard UK and European guidance, let alone the US thresholds for hypertension. And at least a third of those taking medication are currently uncontrolled. Why do we get this poor control? Well, broadly, it's either patient factors or professional factors. In terms of patients, there are issues with adherence to medication, perhaps due to side effects, mismatches of ideals. Some patients are prepared to put up with risk in a different way to professionals, and so may choose not to take medication, particularly for low risks. Lifestyle factors are widely ignored, with most of populations being overweight. In terms of professions, workload's an issue. I'm going to talk briefly in a moment about lack of professional action and guidance changes, as I've intimated. We do have some differences now between the US and European guidance. Some professionals complain about all the different guidelines, particularly general practitioners like myself, who have to deal with not just hypertension, but asthma, epilepsy, and so on. Clinical inertia, though, which affects pretty much every kind of doctor and nurse, is really important. And in the context of hypertension, patients are perhaps seen 3 or 4 times a year, and only at best in half the times in those visits when patients have got a raised blood pressure recorded is anything actually done about it. And this is really important in terms of control. Now, I don't think we can talk about hypertension without, as Brian mentioned, thinking about the impact of the pandemic. This is some data from UK primary care, and you can see the navy blue bars on the chart show that about 2/3 of consultations historically have been face-to-face. In March last year, that started to drop, and then from April onwards, we got really big changes. Only about 10 or 15% of patients are being seen face-to-face. And as Brian said, I think this is extremely likely to lead to long-term changes in care, because by the time we're able to see patients routinely face-to-face, everyone will have changed their practice. And this is really important in the context of not seeing patients, because delaying care can have real impacts. This is some work that was published a few years ago in the BMJ, a nice elegant study that looked at what happens if you delay intensification of antihypertensive medication in the context of a raised reading. And essentially, if you delay for more than about 6 weeks, you get an increase in cardiovascular events compared with immediate action. And the longer you delay, the worse that becomes, and the worse it is for the higher blood pressures. So what about self-monitoring as a potential solution for these issues? Well, I think there are several prerequisites. And the first one is you need patients who are willing to measure their own blood pressure. These are data from all over the place, Italy, Canada, US, China, UK. And you can see that perhaps at least a third of primary care patients, maybe 40%, are self-monitoring, have their own monitors now, higher in some of the specialist settings, such particularly in the US and Italy. We need validated, accurate monitors. And as Brian showed you nicely towards the end of his talk, these are now really quite commonplace. And this is an example of one working with a smartphone. And they're beginning to have links to electronic health records. This is a link in the UK using the Apple Health Toolkit. And those links are really important, because without those links, clinicians don't necessarily have access to patient self-monitored recordings. What about patients' own monitors? This is a concern that many colleagues have. And so we looked in the UK at 7 general practices and looked at over 300 patients' own machines. And we put them through exactly the same kind of test that is done annually to check that the monitors in your own clinic are accurate. And we found that 75% passed every test, both the monitor and the cuff. And the ones that failed, roughly half of them were due to cuff failures and half due to monitor failures. Where the monitor did fail, it usually overestimated rather than underestimated, which I think is reassuring that we're not going to have massive underestimation of blood pressures from patients' own machines. But the bottom line here was that the monitors that were up to 4 years old, only about 5% failed, compared with 25% in 5 years or older. So relatively younger machines that were validated and that cost more than about £10 or €15 were less likely to fail. Large cuffs were more likely to fail, which is important when we think in the context of some of our populations. Now, as well as patients measuring their own blood pressure, we need willing clinicians. And in the UK, we see pretty much universal use of self-monitoring now. 97% of GPs surveyed in 2015 had patients who self-monitor. About half of them had monitors to lend out, although that's clearly difficult at the moment, as is allowing patients to use monitors in waiting rooms, which historically have been common. Self-monitoring previously, prior to the changes in guidance that we had about 10 years ago, were less commonly used in diagnosis, but now about 60% of clinicians are using self-monitoring for diagnosis, and self-monitoring for the ongoing management remains extremely common. What about evidence of benefit? Well, until recently, some of the initial trials titrating against home readings were rather disappointing. So we set out to do a trial looking at the efficacy of primary care practitioners titrating antihypertensives using self-monitored blood pressure, either with telemonitoring or manual self-monitoring. And we did this in the context of the Tasmin-4 trial. We included people whose blood pressure was over 140/90 in a clinic, but were known to have hypertension, were receiving treatment, and were over 35. We excluded those taking more than 3 antihypertensive agents, or with atrial fibrillation, because monitors don't work very well in atrial fibrillation, or those who wouldn't normally randomize, such as people with dementia or pregnancy. And we randomized a third each to either clinic monitoring, self-monitoring using a manual system, or telemonitoring. And we were powered to show a 5mm difference. This is the recording that was used for the manual group, just a simple chart that may be very familiar to some of you. And those people in the telemonitoring group used a simple text-based digital intervention. We used SMS text because in the context of 5 years or so ago when we were setting this study up, smartphones were not particularly common in the age group 60s and 70-year-olds that is most common in hypertension. The text-based system allowed them to send in blood pressures, and it gave them reminders and warnings if their blood pressure was very high or very low, and told them to go and see their family physician if their blood pressure was consistently raised. After a year, the people in the telemonitoring group had just under a 5 millimeter systolic reduction, which was our primary outcome. And that was significant, as was the difference for self-monitoring compared with usual care, which was a little lower. At 6 months, the telemonitoring group was also significantly lower than those in usual care by about 3.5 millimeters of mercury. Self-monitoring alone was not significant at 6 months, suggesting that the telemonitoring gave you better control quicker. We had a good amount of follow-up, 85% at a year, and doing the statistical techniques to check what the effect of including those people not followed up showed exactly the same kind of results. The intervention seems to have worked due to increased use of medications in both the telemonitoring and the self-monitoring group, and importantly there was absolutely no difference in adverse events. We looked at cost effectiveness, and according to the current NICE guidance, both self-monitoring and telemonitoring were cost effective, with little to choose between them when they were directly compared. So this is good evidence for physicians using self-monitoring to titrate. What about if you give patients more control? Well, here are two trials which we did looking at self-management, so self-monitoring with self-titration, both in normal hypertensive populations and in those with multimorbidity, including things like coronary heart disease or stroke or diabetes. Brian was involved in both of these trials. What do I mean by self-monitoring? Well, as I say, self-titration following a pre-specified schedule with or without telemonitoring. GPs and patients decide on a recipe, essentially, of medication changes at the beginning, and they can make those changes in the light of raised blood pressures without needing to reconsult. And things like blood tests, if you're titrating an ACE inhibitor, are possible as well. This concept of setting goals in advance, I think, is really important. Thinking about what the patient is taking, what intolerances they might have, what changes that they could make in the future, and reassuring them that this kind of titration to target is effective and has been done by many patients before. Our interventions tend to use a traffic light type system. These are now automated, as I've mentioned, through smartphones, but red, amber, green, blue on a chart, with red very high, blue very low, green being well controlled and amber being raised, and if it's consistently raised in the amber region, leading to medication changes. And in both of these trials, we got significant reductions in blood pressure at 1 year, both in the essential hypertensive group at the top, about 5.5 millimeters of mercury lower systolic, and in the high risk group, which, as you can see, was nearly 10 millimeters lower, which I for one was surprised that we got a better result in the higher risk group. About 80% of patients managed to do this for 12 months, so it's not something that is just being done by a few people. And again, the method of action seems to be increased use of antihypertensives. Importantly, side effects, again, were very similar between the two groups. In the essential hypertension group, the only thing we picked up was a little more ankle swelling in the intervention group, presumably related to increased use of calcium channel blockers. In the high risk group, there's absolutely no difference. Again, cost effectiveness is something we looked into with modelling, and both interventions were highly cost effective, with the high risk group, because of such a big lowering of blood pressure, actually what's called dominant, which means it was both cheaper and more effective. We looked at whether patients followed the instructions we'd asked them to do, and we found that about 55% of the time they did the up titrations that were recommended by the protocol. In the essential hypertension group, 70% in the high risk group. And you might think, well, okay, then maybe half the time the patients aren't doing what they're supposed to, or 70% of the time. However, look at the trials. The best that doctors have managed in these circumstances is about 45% of the time, and the rest of the time they find a reason not to do the titrations. So these systems work best, as I've mentioned, if you can have a digital intervention, because it makes life easier. It allows medication planning, it allows prompts for patients and healthcare professionals. It allows improved communication and feedback. And you can do things like training. So we set out to look at this in the Home BP trial, which was published in January of this year in the BMJ. Again, Brian was part of the team here with myself and other colleagues. Here we compared a digital intervention, which was a web-based interface, using the same kind of feedback that I've just described. There was training and lifestyle advice available, and we again aimed to improve blood pressure control. Again, our primary outcome was systolic blood pressure at a year, and we found a significant reduction in the intervention group, this time of about 3.5 millimeters of mercury. Again, there was no difference in side effects and high medication adherence throughout. However, this more recent work, about 50% of the control group were doing ad hoc self-monitoring, which might be one reason why the primary outcome was slightly less effective than in the other groups, although the confidence intervals overlap, so it may have just been the play of chance. It seems again to work through medication changes. We had very high levels of engagement, 70% still monitoring after 9 months and still making changes in their medication, both for dose increases and addition of new medications. Some of the algorithms used in that study and in the Tasmin work have now been incorporated into a new intervention called Hypertension Plus, which Omron is trialling in 3 areas of the UK. And the first practices have gone live in the last week or 2. Patients follow very similar algorithms to the ones that I've been describing in terms of their monitoring, and doctors get dashboards like this. On the left, you can see that those with the highest blood pressures are shown in red, and those who are well controlled are further down on the list. You can't see them, and they get charts. You can see it allows them to put treatment plans so that patients then can automatically get prescribed medication as their blood pressure remains high. So how do we fit this all together? Well, the overall effect of self-monitoring seems to depend on what you do alongside it. Just giving people a blood pressure monitor, as you can see in trials at the top of this systematic review, doesn't really do very much. However, once you start doing things like telemonitoring, you can see here, or really quite intensive interventions involving things like pharmacists phoning people up, you start to get really decent improvements in blood pressure control. Having said that, if all you can do, because it's a pandemic, is give someone a blood pressure monitor, you're getting very equivalent control to clinic readings. So we shouldn't, in the current context, we shouldn't forget that. So in conclusion, many patients have suboptimal blood pressure control. This is likely worse because of the pandemic that we've had for the last year or so. We now have a very virtuous circle, including willing patients, willing clinicians, accurate monitors, and effective interventions. And all of these can combine to give us successful telemonitoring. Titration of antihypertensives is effective using self-monitored readings and is cost effective. And digital solutions, including telemonitoring, allow greater intensity of intervention without increasing primary care workload. Clearly, this work was not just done by myself, and this is a very large group of people who've helped in those trials, as I say, including Brian. And much of it is funded by the National Institute of Health Research in the UK. And clearly, we wouldn't have been able to do any of this without our colleagues in the practices and without the patients who took part. Thank you very much.
Thank you, Richard. That was a terrific summary of an amazing amount of work, which actually is really now coming into its own, I think, with the emergence of home blood pressure, self-titration, etc. We started late, we're a little bit over time, but I would like to ask a couple of questions. So firstly, home titration. My sense is that certainly with the new guidelines that we have with simplifying treatment, Richard, with single pill approaches, combinations, very easy to use, I guess in many ways the two things blend together quite nicely. It should be easier to give a patient a treatment plan that said, monitor your blood pressure. If it doesn't go down to below this level within 3 months, add this drug or take this one. I mean, is that something you're doing in practice, or is it still in a research mode?
Yeah, no, it's definitely something that I'm doing in practice. As you know, in the UK, some of the combination medications that are available in Europe are harder to prescribe in primary care. But certainly, you know, I would frequently give someone a lower dose of a medication and say to them, you know, your target's 135, 85. If you're not there in a month of taking this lower dose, then double it. Have a blood test if you're going to do that. If it was an ACE inhibitor, for example, or just send me an email with your results and tell me what you're doing. And many people have done this, including I might add a Nobel laureate who I'm looking after at the moment has done this very successfully.
Fantastic. And another question here. One of our colleagues commenting that really enjoyed the session. We thank you for that. But believes that ABPM is the gold standard at the present time. I mean, just a comment, Richard. I mean, in terms of ABPM use in your practice, and I'll comment for mine.
Yeah, so I agree that in terms of a reference standard, ABPM it has, as you showed in your talk, has got some better outcome data, and I would advocate ABPM for diagnosis in usual circumstances. Now, the problem that we've got at the moment is that many people don't want to come into practices, and practices don't want lots of people coming into them. So I think in that context that home monitoring is very important in terms of diagnosis. What I would say the main place for home monitoring, however, is, as I've been talking largely about, is in the ongoing management, because it's really not feasible to use ambulatory monitoring routinely for titrate antihypertensive medication, unless there's something odd going on. Whereas everyone pretty much, I think, could or should have a home monitor at home now to be used in their day-to-day management.
Yeah, and the other thing for me is when we're doing guidelines, we often use the two terms interchangeably, and in reality, they're really, really different. What I tried to emphasize in my talk was, you know, home blood pressure traditionally has been a seated measurement, and ambulatory is by definition ambulant and captured nighttime blood pressure as well, but did it all on one day. So is that a work day or a weekend or whatever, or a stressful day or a non-stressful day? Whereas the advantage potentially of home, particularly as the monitors get more sophisticated, is you can capture many more days, which has to give you a better feel for the overall blood pressure. And particularly as we move towards monitors, which can also measure blood pressure during activity as well as just at rest and at night, potentially in the future. I think those sort of things might actually transform the use of a home and give us perhaps more information than we'll get from a single ABPM. What do you think about that?
Yeah, no, I agree, and I do think that as you intimated, with some of the new technology that maybe if we look a decade hence may well come in where cuffs perhaps become less commonplace and we start getting accurate cuffless measurement or continuous measurement with people wearing devices such as watches and so on. The line between what's home and what's ambulatory and becomes much more blurred. Now, clearly, we're not at the point at the moment where we've got accurate monitors that can be used day to day in those sorts of circumstances, or at least not many of them. But I don't think it'll be too long, and then maybe these perhaps slightly artificial differentiations that we're making will cease to be an issue. Also, there are people who get raised blood pressure on a home reading but normal ambulatory, and vice versa. And quite what you do about those, I suspect that probably everyone at some stage needs to have ambulatory home and clinic monitoring so that one can really take into account the full aspect of their underlying risk, which is after all why we're doing this.
Yeah, and I can tell you, we were talking before we started about whether we get a lot of questions. We've got so many questions. Unfortunately, we haven't got enough time to address them all. And I think what this sends as a message to the organisers is we need more sessions on blood pressure measurement and out of office blood pressure measurement, because it's so relevant to all of our practice. And there's still many unresolved issues amongst clinicians about what we should be doing. But anyway, I hope today's session has helped you clarify some of these points. Thank you so much, Richard, for your excellent contribution, and thank you for watching. I'm going to have to close the session now for the sake of time. Thank you very much.
Thank you.